Anticoagulation Principles, Warfarin, Part 4, Management of Bleeding and Counseling. We have reached the final section of our discussion of Warfarin, Part 4, Management of Bleeding and Counseling. First, we'll talk about Warfarin's number one adverse drug reaction, bleeding. Bleeding is the most common adverse event of Warfarin. The incidence ranges from 6 to 39%. Life-threatening or fatal bleeding occurs between 2 to 8%, usually if the INR is greater than 5. The GI tract is the most common site of bleeding, and it also can occur in the urinary tract. Intracranial bleeding is the most serious type of bleeding. Patients should report any signs of bleeding or bruising to the physician while on Warfarin. Either blood in the urine, sputum, or stool, minor nosebleeds, or gum bleeding after brushing their teeth. Warfarin carries along with it a black box warning for bleeding risk. Warfarin can cause major or fatal bleeding. The most important factor influencing the risk of bleeding is the intensity of anticoagulant therapy. A number of studies have shown a steep increase in hemorrhagic events as the INR goes above 5. Several patient characteristics have been shown to be associated with a higher risk factor of bleeding during warfarin therapy. A history of bleeding, especially GI bleeding, has most consistently been demonstrated to be predictive of major bleeding. Other factors include a history of stroke, the presence of a serious comorbid condition such as renal insufficiency, anemia with a hematocrit of less than 30%, or concurrent aspirin, NSAID, or steroid use. The relationship between older age and increased anticoagulant-associated bleeding is controversial. The discrepancy may be partly explained by the relative lack of representation in most studies of patients greater than 80 years of age. There is reasonable evidence to suggest that there is a real increase in intracranial hemorrhage in the elderly. Intramuscular or IM injections of concomitant medications should be confined to the upper extremities. This permits easy access for manual compression, inspections for bleeding, and use of pressure bandages. So how do we manage a patient with serious bleeding and elevated INR? First, we hold warfarin, then we give vitamin K 10 milligrams by slow IV piggyback over 30 minutes. Vitamin K administration can be repeated every 12 hours. Then we supplement with fresh frozen plasma, which contains clotting factors. Or we can give prothrombin complex concentrate or recombinant factor 7A, depending on the urgency of the situation. Recombinant factor 7A, or NOVO7, is no longer recommended for warfarin reversal because it only replaces one of the 4 clotting factors inhibited by warfarin, and it has a high cost. What about a patient with life-threatening bleeding and elevated INR due to warfarin? How do we manage these patients? First, we hold warfarin, then we would administer prothrombin complex concentrate or recombinant factor 7A. As we said before, recombinant factor 7A is no longer an option. We would then supplement with vitamin K 10 milligrams by slow IV infusion and repeat this if necessary depending on the INR. We'll go into this a little bit more in depth in the next slides. Let's first talk a little bit about prothrombin complex concentrate, or PCC. Here's a table that shows differences between 3-factor and 4-factor PCC products. 3 and 4-factor PCC both contain factors 2, 9, and 10, but 3-factor PCCs contain little or no factor 7, while 4-factor PCC contains significant amounts of factor 7. 4-factor PCC is available as a product named KCentra and is currently the official antidote for life-threatening overdoses of warfarin. Let's discuss KCentra more in depth. KCentra is a prothrombin complex concentrate containing the vitamin K-dependent coagulation factors 2, 7, 9, and 10, and antithrombotic proteins C and S. Indication: KCentra is a blood coagulation factor replacement product indicated for the urgent reversal of acquired coagulation factor deficiency induced by vitamin K antagonist therapy in adult patients with acute major bleeding or need for an urgent surgery or invasive procedure. KCentra use should be reserved for cases of life-threatening bleeding due to warfarin overdose. Life-threatening bleeding includes patients with intracranial hemorrhage in association with an INR greater than 1.4 in the setting of warfarin therapy, patients with cardiac wall perforation and/or cardiac tamponade in association with an INR greater than 1.4 in the setting of warfarin therapy, or life-threatening hemorrhage in a patient on warfarin resulting in initiation of a massive transfusion protocol. The KCentra dose should be individualized based on the patient's baseline INR value and body weight. This is the table that we will use. First, we determine the pre-treatment INR, either between 2 and 4, between 4 and 6, or greater than 6. Based on that pre-treatment INR, we will then determine the dose of KCentra, which is the amount of units of factor 9 per kilogram of body weight. The maximum dose should not be exceeded for that specified in the table. For patients weighing more than 100 kilograms, the maximum dose should not be exceeded. It's important to note that the KCentra potency in units is defined by the factor 9 content. KCentra is available in two strengths, the 500 unit vial and the 1000 unit vial. The actual potency of the amount of factor 9 within each vial can be plus or minus 100 to 200 units. Sterile water diluent is provided with each KCentra vial. Store the KCentra between 2 to 25 degrees centigrade. This includes room temperature, not to exceed 25 degrees centigrade or 77 degrees Fahrenheit. Do not freeze. Preparation: calculate the KCentra dose based on the patient's weight and INR. Round the dose up or down to the nearest 500 unit increment. Remove the required number of 500 unit and 1000 unit vials needed, along with their provided diluent vials of sterile water. Follow these steps. First, ensure that the KCentra vial and diluent vials are at room temperature. Remove the flip caps and wipe the stoppers with the alcohol swab. Open the mixed 2 vial package by peeling off the lid. Do not remove the mixed 2 vial from the blister package. Place the diluent vial on a clean surface and hold the vial tight. Take the mixed 2 vial together with the blister package and push the spike of the blue adapter end straight down through the diluent vial stopper. Carefully remove the blister package from the mixed 2 vial set by holding it at the rim and pulling vertically upwards. Make sure that you only pull away the blister package. Place the KCentra vial on an even and firm surface. Invert the diluent vial with the mixed 2 vial set attached and push the spike of the transparent adapter end straight down through the KCentra vial stopper. The diluent will automatically flow into the KCentra vial. With one hand, grasp the KCentra side of the mixed 2 vial set, and with the other hand, grasp the diluent side and unscrew the set carefully counterclockwise into 2 pieces. Discard the diluent vial with the blue mixed 2 vial adapter attached. Gently swirl the KCentra vial with the transparent adapter attached until the substance is fully dissolved. Draw an appropriate amount of air into an empty sterile syringe. While the KCentra vial is upright, connect the syringe to the mixed 2 vial's Luer lock fitting by screwing clockwise. Inject air into the KCentra vial. While keeping the syringe plunger pressed, turn the system upside down and draw the solution into the syringe by pulling the plunger back slowly. Now that the solution has been transferred into the syringe, firmly hold onto the barrel of the syringe and disconnect the transparent mixed 2 vial adapter from the syringe by unscrewing counterclockwise. Attach the syringe to a suitable intravenous administration set. After reconstitution, administration should begin promptly or within 4 hours. After reconstitution, inject the entire volume of KCentra solution into an empty evacuated container. Administer the KCentra as follows. Administer the KCentra at a rate of 0.12 ml per kilogram per minute, about 3 units per kilogram per minute, up to a maximum rate of 8.4 mLs per minute, or 210 units per minute. It's usually between 15 to 30 minutes depending on the dose. Do not mix KCentra with other medicinal products. Administer through a separate infusion line. Please note that KCentra comes with a black box warning. Both fatal and non-fatal arterial and venous thromboembolic complications have been reported with KCentra in clinical trials and post-marketing surveillance. Monitor patients receiving the KCentra for signs and symptoms of thromboembolic events. KCentra was not studied in subjects who had a thrombotic or thromboembolic event within the prior 3 months. Other things to do is to administer vitamin K concurrently to patients receiving KCentra. Monitor the INR and clinical response during and after treatment. In clinical trials, KCentra decreased the INR to less than or equal to 1.3 within 30 minutes in most subjects. The relationship between this or other INR values and clinical hemostasis in patients has not been established. The cost of KCentra ranges from approximately $5,000 to $10,000 depending on the dose administered and the acquisition price. What are the advantages of using KCentra over fresh frozen plasma, or FFP? KCentra is faster acting. You get an INR reduction at 30 minutes after the end of the infusion. You get a greater sustained action with KCentra. The INR reduction is sustained for up to 8 to 12 hours. And you use a lower volume using KCentra versus FFP, 85% less volume versus plasma. However, it's important to note this footnote. Due to KCentra's high cost, it should be reserved for cases of life-threatening bleeding due to warfarin. Most cases of serious bleeding that's non-life-threatening due to warfarin can be managed with FFP and vitamin K. What are some other ADRs due to warfarin? Warfarin skin necrosis. Other than hemorrhage, warfarin skin necrosis is the most important side effect of warfarin. It's uncommon, between 0.01 and 0.1%. It's usually observed on the 3rd to 8th day of therapy, and it begins with pain, then an erythematous flush, then petechial hemorrhages, then red, blue, or black necrotic tissue that may hemorrhage. It is seen more commonly in middle-aged obese females and commonly involves the fatty subcutaneous body areas. It's caused by extensive thrombosis of the venules and capillaries within the subcutaneous fat. You get a paradoxical formation of fibrin clots within the microvasculature that block the blood supply to the skin, resulting in necrosis. Surgical debridement is required in half of the cases. The pathogenesis of this complication and the reason for the localization of the lesions are not well understood. Another adverse event due to warfarin is called purple toe syndrome. Purple toe syndrome is rare. It occurs during the 3rd to 10th week of therapy. It's painful purple or mottled discoloration of the toes and side of feet. Warfarin may enhance the release of cholesterol microemboli from plaques on vessel walls. Some progress to gangrene, requiring debridement or amputation. Let's talk a little bit about the antiphospholipid antibody syndrome. The antiphospholipid antibody syndrome, also known as APLA, is an autoimmune disorder where the body develops antibodies against the phospholipids on the surface of the blood vessels. This causes the body to not recognize the surface of the blood vessels as good and instead allows clots to form on them. Here's a normal blood vessel. Phospholipid antibodies, or PLA, blocks clotting factor CF from attaching to the phospholipid surface to form a clot. However, in APLA patients, phospholipid antibody is neutralized, allowing clotting factors to attach to the phospholipid surface to form a clot. APLA is a hypercoagulable state associated with both arterial and venous thromboses. It increases the risk of DVT with an incidence of 30 to 55%, half of these having pulmonary embolism. It's associated with an increase in a woman's chance of recurrent miscarriages. It may be caused by tiny blood clots that block the supply to the placenta. APLAs can be found in 1 to 5% of the population. There are two types of APLAs. One, lupus anticoagulants. APLAs can be found in 30 to 50% of lupus patients. They prolong their clotting assays. And the second type is anticardiolipid antibodies. The presence of APLAs by itself is not an indication for warfarin. Asymptomatic APLA patients without a history of thrombosis may benefit from aspirin 81 milligrams per day. Pregnant patients with APLAs and 3 or more pregnancy losses should be treated with aspirin 75 to 100 milligrams per day and prophylactic doses of low molecular weight heparin or unfractionated heparin. Patients who are treated with warfarin who have a lupus inhibitor and have no additional risk factors and no lack of response to therapy, a therapeutic target INR of 2.5 with an INR range of 2 to 3 is suggested. For patients with antiphospholipid syndrome with previous arterial or venous thromboembolism, warfarin therapy titrated to a moderate intensity INR range of 2 to 3 rather than a higher intensity is recommended. Here are some key contraindications to warfarin. Pregnancy, first trimester. Warfarin crosses the placenta and is a teratogen. Avoid throughout the pregnancy, especially the first trimester. Use heparin instead. Other contraindications include overt bleeding or active ulcerations of the GI or respiratory tract, current or recent CVA, blood dyscrasias prone to bleeding, recent or planned neuro-ocular or traumatic surgery, spinal puncture, pericarditis or pericardial effusions, malignant hypertension, or eclampsia. Now let's go over some patient counseling tips. Here's some information to give to patients who are taking warfarin. Strict adherence to prescribed dosage schedule is necessary. If a dose of warfarin is forgotten, take the dose as soon as possible on the same day. Never take a double dose of warfarin on the next day to make up for missed doses. INR tests and regular visits to the physician or clinic are needed to monitor therapy. Carry identification stating that warfarin is being taken. And do not take warfarin during pregnancy, and do not become pregnant while taking it. Do not take or discontinue any other medication except on the advice of the physician, including salicylates, over-the-counter medications, and herbal products. Avoid excessive alcohol consumption. The amount of vitamin K in food may affect therapy of warfarin. Eat a normal balanced diet maintaining a consistent amount of vitamin K. Avoid drastic changes in dietary habits, such as eating large amounts of green leafy vegetables. Also, avoid intake of cranberry juice or any other cranberry products. Contact your physician to report any illness such as diarrhea, infection, or fever. Notify the doctor immediately if any unusual bleeding symptoms occur. This includes pain, swelling or discomfort, prolonged bleeding from cuts, increased menstrual flow or vaginal bleeding, nosebleeds, bleeding of gums from brushing, unusual bleeding or bruising, red or dark brown urine, red or tar black stools, headache, dizziness, or weakness. Avoid any activity or sport that may result in traumatic injury. If therapy with warfarin is discontinued, patients should be cautioned that the anticoagulant effects of warfarin may persist for about 2 to 5 days. In Part 4, we listed the adverse effects of warfarin and patient risk factors for bleeding. We summarized the antiphospholipid antibody syndrome. We described KCentra, what dose to use, and how to prepare it. And we went over what type of counseling information should be provided to a patient taking warfarin. We've got a lot in store at the PharmEasy Tutor channel. There will be upcoming talks on anticoagulation, specifically heparin and DOACs, electrolyte management, quinolone side effects, drug overdoses, and much, much more. So please stay tuned to us. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.